Thank you very much, Sharon. Congratulations for surviving until Friday. I've been screaming for 40 years that endotracheal intubation creates a cardiovascular crisis, and I'm absolutely delighted that there's a session on that. My conflicts of interest have nothing to do with this. As you heard, the multi-center study showed that emergent intubation is associated with cardiovascular insufficiency. Now, what they didn't say, but was part of those studies, is that a significant number of emergent intubations do not occur in the intensive care unit. They occur on the floor. They occur in the emergency department. And though I really like having a whole bunch of people around when we have to intubate someone, because I used to teach the difficult airway management course, which is called the DAM course, we often don't have those opportunities in the middle of the night. And with the study by Bowles that you cited was all on emergent intubation on the floor, and that was from our institution. And we found that there were 25% of the patients emergently intubated on the floor remained hypotensive for more than 1 hour. So this is a very big deal, and it's not surprising to me that fluids don't do anything, because fluids rarely do anything, and it's the wrong mindset in most of the patients once you understand the mechanism of disease. I like the fact that propofol was shown to be bad, because it should be bad, because it's a profoundly suppressive agent. I've always used etomidate. I've gotten to use ketamine lately because all the residents want me to use it, but that's the only reason I use it. But they have a nice profile. Remember, you have to be a pharmacologist, and when you're doing these, you have to understand how the drugs work, okay? So there are very simple things that happen with endotracheal intubation, and they all can screw up the cardiovascular system, some of which you can treat beforehand, but some of them are due to the intubation itself. Intubation will require sedation. I'm a big fan of awake intubation in the sickest people, and those are what I try to do, but oftentimes you don't have that option. If you don't understand that one of the reasons why patients crash and need to be intubated is they already have cardiovascular collapse. The most common cause of intubation, though, is respiratory failure. And most of that respiratory failure is not ARDS. It's chronic obstructive pulmonary disease, so it's a different process. In the ICU, it's ARDS, but on the floor, it's COPD. And positive pressure breathing, as I'll describe in a second, causes an elevation of index expiratory pressure, and it's going to cause hyperinflation. So if we think about changes in lung volume and changes in intrathoracic pressure, one of the most important things that increasing lung volume does, especially in patients with airflow limitation, is increases the resistance of the pulmonary vasculature, because the alveolar vessels for the same transpulmonary pressure have a higher resistance. If you were to look at a normal pulmonary vascular profile from residual volume to total lung capacity, the lowest pressure the resistance you have is at functional residual capacity. But if you look at why this is the case, the alveolar vessels have no tone, so they have no resistance. But as you increase transpulmonary pressure, airway pressure to pleural pressure, when it exceeds left atrial pressure, the vessels spontaneously collapse, cross-sectional area goes down for the vessels, and therefore by definition resistance goes up. And this is what you see in all COPD patients and respiratory failure. In the patients with ARDS, they have small lung volumes, and by the process of hypoxic pulmonary vascular resistance, increases the tone in the vascular vessels, and therefore the extraalveolar vessels go up. So any patient that you're intubating is going to come to you with a high pulmonary vascular resistance to start with, and if it's new, it'll cause them to have right heart failure. Increases in lung volume above FRC increase pulmonary vascular resistance, and hyperinflation is profoundly common. And what I wanted to share with you is that if you think about the classic physiology, that your lungs have a compliance and you breathe out passively against an airway resistance, that the rate of fall is simply the time constant times the temperature, and this is, times the volume. So classically tau, which is resistance times compliance. If the resistance goes up or the compliance goes up, think COPD. In all cases, they'll have a longer time to breathe out. And this is a big deal, because look at this picture. If I take a bag ventilation, and a bag for bag mask ventilation has a volume in it of 3 liters, and I simply do this, I may give the patient a 15 ml per kilogram tidal breath for a single breath. And I don't know if you've ever seen what the respiratory therapist does when you intubate the patient, but they give them a really big bag and everyone smiles. It's the chicken soup philosophy of life. It's a little good, more is better. But I want to show you that 3 breaths of a large tidal volume in a patient with chronic obstructive lung disease can double their FRC. They rapidly hyperinflate. So by the time you turn around and make sure that the airway is secure, they're already hyperinflated. Okay, period. This is not a minor point. They don't go up and explode because as the lungs get bigger and bigger, the compliance goes down and the resistance goes down as well because the airways are bigger and you reach a new steady state, but you reach a new steady state at a very high lung volume. And this was known for years. This is a COPD patient that John Marini and Paul Pepe showed in a review of occult PEEP in a COPD patient. And when it was published in the Blue Journal, it wasn't even considered a paper. It was a clinical commentary because the reviewer said, we already know this, but we don't practice with it. So when the lungs inflate, the chest wall can go up, the diaphragm can decrease, but the heart is trapped in the cardiac fossa. And if you look at the effects of increasing intrathoracic pressure on left ventricular function, you can see it's not rocket science. Look how small you make the heart. This is not a volume responsive decrease in preload. When you think about how increases in intrathoracic pressure affect venous return, you can do it from a classic venous return curve. Here's your ventricular function. There's your normal venous return. This is your equilibrium point. We all live there. As I showed in 1984, that with spontaneous breathing, you get increase in venous return, but with the positive pressure breath, as you decrease the venous return, stroke volume goes down. And everybody now knows this. And I presume somebody in this room was not yet born in 1984. So I can comfortably tell you, we knew this before you were born. Okay. So what happens with positive pressure breathing? You increase the heart and the chest, but that decreases cardiac output and blood pressure falls. And this happens in everyone, and especially common in the operating room. In the operating room, since they have control of it, they can give volume or pressors, and they will simply increase venous return. Intubation must induce a form of cardiovascular collapse, which will be more obvious in the hypovolemic patient, because in the non-hypovolemic patient, as the diaphragm descends with positive pressure breathing, it increases intra-abdominal pressure, preventing the fall in venous return. Okay? And the greater the tidal volume, as we showed in this study, from 5 to 10 to 15 to 25 mLs, the greater the amount of flow that leaves the chest. As you can see in this picture, as you go from 5, look at how much volume leaves the chest. You basically are having a profound effect. On the other side, increases in intrathoracic pressure will decrease left ventricular afterload. And one of the things I like to explain to people is the afterload in the left ventricle is the transmural pressure. And it's really hard to explain transmural pressure, so I show them a picture of my children. Isn't that nice? Stephanie, Daniel, and Joe. Do you care how tall my kids are or how high their heads are above the water? It is their height of their heads above the water that is their transmural pressure. So in a study that we did in 1979, we looked at the effects of increasing intrathoracic pressure with the Valsalva maneuver on human beings, and what we found was that as you give the Valsalva maneuver within the first 3 beats of bearing down increasing intrathoracic pressure, as you can see in these humans, the end diastolic volumes profoundly decrease. Stroke volume remains constant because you're decreasing afterload, but if you're sustaining this, it won't stay there. So let's go back now and figure out what happened to all those patients that when emergently intubated had cardiovascular collapse. Once again, a majority were patients with respiratory failure. The second most common cause is neurologic dysfunction, and that's true across most studies. Number 1, emergent intubation must result in loss of sympathetic tone. There is nothing more stressful than not being able to take a breath. It is, if you can't breathe, nothing else matters. And therefore, a person that comes in acute respiratory failure is going to have a massively elevated sympathetic tone. Merely putting them on sedation, fentanyl, and sometimes etomidate, by reducing the vasomotor tone, will decrease arterial pressure, increase the pooling of blood in the periphery, and cause hypotension. This will cause the blood pressure to fall, and if the diastolic blood pressure falls too much, you decrease coronary perfusion pressure and you get a primary myocardial depression. You get a decrease in unstressed volume. You also see the increase in intrathoracic pressure. At the same time as the mean systemic pressure is falling, the right atrial pressure is rising, so your pressure gradient for venous return is lost. And if you have hyperinflation, which occurs commonly, you're impeding right ventricular function, so at the very time the right ventricle needs preload, it's decreasing its volume, but if you give them too much preload, since they're in right heart failure because of the hyperinflation, they will go into further failure. Almost none of this is fixed by volume alone. Almost none of this. What needs to be done initially, and I strongly support what Sheila is trying to do with her study, is you want to give them vasopressors. You can give a little bit of fluids because the treatment for everything we do in the ICU is to give fluids. I don't know why, but that's what we do. I can't tell you how many times I've said, patient's not doing well, so I gave him 500 of Ringer's lactate or something. I say, why'd you do that? Well, they weren't doing well. What do you mean well? You know, so that's what they do. So to address this issue, we should use a vasopressor. And the vasopressor of choice is norepinephrine. Please do not use phenylephrine. Phenylephrine has no beta effects and will therefore only cause the heart to eject less at a time when you need it to have more. Norepinephrine is the pressor of choice, and you can, if you are not emergently intubating someone on the floor, and you have the ability to start a vasopressor beforehand, that's wonderful. But if you don't have the ability to do it, it should be available to start. I strongly agree with Paul Mayo, who showed in a study in New York that you can give norepinephrine peripherally, and that the complications are almost zero, and they're no worse than peripheral phenylephrine, which we do all the time. So I would start norepinephrine as necessary. And how much norepinephrine do you give? I have no idea. Let the patient tell you. Let the patient tell you. You want to prevent hypotension from occurring or rapidly reverse it. It's a transient phenomenon, and as long as you haven't created profound hyperinflation, they will be fine. With regards to the increase in intrathoracic pressure and lung volume, hyperinflation is a very big deal and is often ignored. So you have to treat the patient as a pulmonary doctor would, with decreasing tidal volume, prolonged expiratory time, but everyone's giving big breaths because they're so happy they've got an airway in, okay? And that's going to increase dead space, increase shunt, and make oxygenation worse. So you have to avoid hyperinflation by doing the strategies that we know work to prevent it. So in summary, there are many causes of cardiovascular insufficiency around emergent intubation. Okay? There's immediate loss of sympathetic tone, but the good news is that's reversible. Sustained hypotension probably is not due to the sympathetic tone loss, but is due to other issues such as hypovolemia, but these are rarely fixed by fluids alone. If you avoid or minimize hyperinflation in the chronic obstructive lung disease patient, it'll do a lot of good for you. You want to give, therefore, the minimal tidal volume and PEEP. That's just how you prevent hyperinflation. And you want to support the arterial pressure with pressors. And this is exactly what they're going to do in the trials. And this makes sense physiologically, because this will decrease your unstressed volume and be much more effective and fast at increasing venous return, because it makes the circulating blood volume effective to make blood flow. And with that, I thank you for your attention.
Thank you very much for this wonderful talk. Is there any question in the audience? I have one question regarding administration of vasopressors. How do you administer vasopressors? Do you always use a central venous access or over means?
I try never to say the word always. okay? If I have a central line, I use a central line, but if the patient is on the floor and they've been emergently intubated, and we're trying to take them to the ICU, where they're telling me if a bed's going to be available, et cetera, and they have a peripheral line, I will give norepinephrine through the peripheral line. I and attendings in critical care medicine in our department are certified to do that. The residents can't write those orders, okay? But if I'm there, I say give it, okay? And I take responsibility. It's not an issue. It's not a worry. Do it. So the answer is yes, but when they come to the intensive care unit, then we want a stable line for various other things. We'll put in the central line under ultrasound guidance, of course, with the masking and gloving and all that stuff you do, and then we'll switch the norepinephrine there. But we do not delay the norepinephrine infusion until we have a central line.
Thank you. It's very important, yes.
So I'd like to you to elaborate a little bit more on two of these points. One of them is what's your approach towards bolus drugs during our pre-induction? In the operating room, many times people use ephedrine. And the second question has to do with the timing of administration. Do you start norepinephrine before you induce or after induction once you see a trend?
It depends on the patient. If they're, I don't do surgery in the operating room and induce anesthesia, but in those patients, you have complete control of the environment. You know when the intubation is going to happen. You schedule it on the clock. And in those situations, I would wait for something to happen. And if they want to give a touch of ephedrine or phenylephrine once to prevent hypotension, even though it'll make cardiac output fall, it won't hurt the patient if done once. Okay. In the ICU, if we're going to be intubating someone, I want to have norepinephrine available, but because we also have a lot of patients that have other issues, I'm trying to keep the blood pressure in a constant level, and if it starts to fall, we will go up on the norepinephrine. The problem I get is from the nurses who say to me, do you want me to mix up norepinephrine and put it on up here on the patient's bed when they're not getting it right now? That takes a lot of effort, and I have to have the infusion pumps, and if I'm not turning it on, why am I bringing it there? Because I lose it. I have to throw it away. And this is sometimes what people say to me. And so you have to address the issue that there has to be a process by which the entire staff understand that the cardiovascular support during an emergent intubation is one of the most important things they're doing. Now, after a few times of doing it, I don't get grief from the nurses, but it is a conversation I must have. So the answer is yes. I also, unlike what Sheila does, when I give low dose of norepinephrine, I give a small bolus first so that you reach a steady state. Because if you infuse a low dose of norepinephrine, it takes a while for it to reach its state because remember, O-methylesterase metabolizes it. So just as you're infusing it, it's going down, so you need to have a little bit of a bolus. How much? I have no idea. But you let the patient tell you what their response is.
So again, to be clear about the technicalities here for the audience, are you going to give a bolus of norepi, start a drip, and then give your drug, whatever it is? Or are you going to have it in standby, give the drug, and then give the bolus and start the drip,
Okay.
if required?
Okay. Almost always we give the sedation and start the intubation, and if necessary simultaneously, because I don't have to press the buttons on the pump for the norepinephrine, we just say, okay, start the norepinephrine. If we don't see hypotension, every drug is a poison, and if I don't need to give norepinephrine in this patient, I'd be happy. So no, I do not give norepinephrine on every intubation whatsoever, but it's sitting right there.
Other questions? Yes?
Someone had a question. I saw them stand up. Okay, guess they're on.
Okay, so I think we can conclude. Thank you very much to all the speakers. It was a very good session.